To everybody. I'm David Sandman. I'm President and CEO of the NYHealth Foundation. It's a beautiful sunny day here in Albany. It's great to be in the Capitol with you all. So thanks for joining us, either in person or we've got quite a crowd joining us online as well. So welcome to all of you. For those of you who might not be so familiar with the NYHealth Foundation, we are a private, independent, and statewide foundation with a mission to improve the health of all New Yorkers, and that includes the more than 600,000 veterans who call New York their home. In addition to our work on veterans, we focus on connecting people with the healthy and affordable food that they need. We work to enhance primary care access and quality across the state, and we maintain a pool of flexible funding through our Special Projects Fund. So you can learn more about all the foundation's work on our website, nyhealthfoundation.org. I encourage you to go there, sign up for our email alerts. You can pick and choose which ones you want to receive so you don't get too many of them. And of course, you can follow us and follow me on all of your favorite social media channels. I like to say, if you do, we'll follow you back. You have to give love to get love. So let's get some new followers going today. But today we're all about our veterans' health, and our veterans' work is led by my colleague, Derek Coy. And our work on veterans does have some core priorities. First, improving access to, every word here matters, high quality, culturally competent health care and mental health services, and that is whether they choose to get care in community settings or at the VA. Often they do so in a sort of mix and match way, and that's one of the things we'll be talking about more today. We focus on preventing veteran suicide and expanding and strengthening the role of peer mentors. Peers matter. They promote social connection. They offer support from people who get it, who personally know what you're going through. And they play a key role in veterans treatment courts, or VTCs. Sometimes they're called the special sauce of a VTC, another topic where the foundation's been very active. This is an expert crowd. Many of you probably know about veterans treatment courts, but again, just in case you don't, VTCs are for veterans who have a mental health, substance use issue, or both, and who have found themselves in trouble with the law. They provide an alternative to incarceration, and instead of jail and the classic revolving door, veterans instead receive treatment and a chance to get their lives back on track and contributing to their communities. It's a big point of pride that the first VTC in the nation was a New York creation. It was established in Buffalo, the first one of its kind. And I like to say you can't keep a good idea down. VTCs have spread like wildfire, both across New York State and across the nation. But despite that, there were still veterans in New York who couldn't use one because there was no VTC where they live. And that too has changed. New York State enacted a law creating universal access to VTCs for all veterans who need one. So if you live in a county without a VTC, you can have your case transferred across the county line to a county that does have one, so that all veterans can benefit and no one is left behind just because of where they live. All right, so maybe you're wondering, those all sound pretty good. There's so many things they could be doing. Why'd they pick those? And the answer is really simple. We listened to veterans themselves. When we started our work on veterans well more than a decade ago, really about 14 years ago now, the foundation commissioned our friends and partners at RAND to conduct a statewide veteran needs assessment. And veterans told us directly what they wanted, what they needed, whether or not their needs were being met, and how. And ever since then, listening directly to and being guided by the voices of veterans has been the North Star for our work. That initial study produced so many important findings, but it's getting old. That study reflects the needs of veterans way back in 2010. A lot has happened and changed since then, and I mean a lot. For starters, the veteran community itself has changed. It's becoming more demographically diverse, with growing shares of non-white and women veterans. A lot of changes in healthcare coverage and policy have happened, things we'd never even heard of 14 years ago, the Affordable Care Act, or Obamacare, the Choice Act, the Mission Act, all of them collectively have led to an increased reliance on private sector care. Over those 14 years, new issues have emerged, or others are getting the attention that they deserve. Things like burn pit and other toxic exposures, veteran suicide, an opioid crisis that has left virtually no community untouched, and more attention to sexual assault in the military as well. And here at home, a lot has also changed. Back in 2010, the New York City Department of Veteran Services didn't even exist. No such thing back then. The state's Division of Veteran Services had not yet been elevated to full departmental status. We didn't have statewide access to veterans treatment courts, and we also had not seen the explosion of telehealth that resulted from the COVID pandemic. And I can't help but mention that the last few years have also been particularly trying for veterans in some ways. In addition to COVID, it wasn't that long ago that we experienced the 20th anniversary of 9/11, which led to really the creation of the post 9/11 generation of veterans, led so many to step up and serve their country, and then, rolling forward, experiencing a very violent and very chaotic withdrawal from Afghanistan that raised some of those memories. So when you put all that together, we were overdue. It was definitely time for an update. We needed current information about veterans' needs, experiences, preferences. So what's old is new again. We turn to our partners at RAND yet again. This new assessment gives us insights about New York's newest veterans and offers a roadmap for the foundation and our partners and others across the country and in other states who are working to understand and meet veterans' needs. So I couldn't be more thrilled to be here this morning. This is the very first public release of the new findings from this updated assessment. Joining us this morning is the lead author, Jeanne Ringel, who's going to share the results and implications. She'll go over those. We're going to have some time for conversation. If you check out the QR codes in your packages, you can see the full bios for all of our speakers today and the agenda and so on. But Jeanne is director of the Access and Delivery Program and a senior economist at RAND. She's also a professor of policy analysis at the Pardee RAND Graduate School. Following that, we're going to do a very quick transition into a panel led by my colleague Derek Coy. And really, for me, that is also living our values. We do not talk about veterans, we talk with veterans. And so we will have a panel of veterans reacting to the results, telling us what does not resonate, and sharing some of their own experiences. That's a lot to dig into, so let's get on with the show. Let's give a big hand and welcome Jeanne.
Thank you, David, and thank you all for being here. I'm really excited to be with you to share the results of our study on the health and well-being of New York's newest veterans. I'm Jeanne Ringel, I'm from RAND, and I wanted to just say a little bit about RAND. RAND is a policy research organization, and we're dedicated to identifying solutions to public policy challenges that aim to help communities become safer and more secure, healthier and more prosperous. And in particular, within the Epstein Family Veterans Policy Research Institute, we're really dedicated to conducting innovative and evidence-based research that's focused on improving the lives of those who have served in the U.S. military and those that care for them. So in today's talk, I'm going to just give you a little bit of information about the study and the motivation behind it, though David has given you a lot of that background already. We'll talk through some of the results related to health and well-being of veterans in New York State, whether and how they're accessing care and sort of the experiences with VA and community care, and then some of the recommendations that flow from the results. So just a bit about the study. As you know, many U.S. military members leave active service and transition into civilian life without any trouble. They work, raise families, contribute to their community. They bring their skills and experience from the military and put them to work in productive ways in the community. But for others, that transition is not as easy. They may grapple with mental and physical health challenges related to their service, and really trying to address those challenges is crucial. And policymakers at the state and local level are particularly important in this response, because it's at the state and local level that policies and programs can be tailored in such a way that they really meet the specific and unique needs of veterans in their community. And that's really what the foundation was after here, in trying to understand what were the needs of veterans in New York State, and how can this information then feed into their programs and policy and work that they're doing in the state. And that can happen throughout there. So we conducted a survey of recently separated or discharged veterans in New York State, those that had been leaving active service between January 2018 and January 2023 and lived in New York at that time. It was a random sample, and we received responses from 1,122 veterans with enough information to include in our analysis. So just a little bit about the sample. As you would know, sort of the overall general population or composition of veterans has been changing over time, and we see that in this new cohort of veterans in New York State, where they're relatively young, as you might expect, as they're recently discharged. We saw about 40% were under the age of 35, and nearly 2/3 were under the age of 45. We see 15% as women, 40% as non-white. A little over half of the people in the sample had served in the Army, and about 60% had deployed on at least one combat mission during their time. Now, compared to the sample that was studied in 2010, this group is a little bit older, more likely to be female, more likely to be from a racial or ethnic background, and less likely to have served on a combat mission, because serving on a combat mission was a requisite of inclusion in the prior study, but we did not require that here. So let's turn to the health and well-being outcomes that we looked at. First, focusing on mental health. We looked at whether or not veterans had probable diagnosis for a number of different mental health conditions. And we found that in this sample, approximately a quarter screened positive for probable depression, 26% screened positive for probable PTSD, and a good proportion, 17%, had screened positive for both. We also saw suicide ideation rates at about 9%. Among those 9% that had thought about suicide in the prior year, 11% reported making plans to commit suicide, and a little under 1% reported an attempt. These numbers on the proportion reporting mental health conditions has increased since the 2010 study. The 2010 study found about 16% of screening positive for both depression and PTSD. And this increase reflects or is consistent with sort of an overall increase we've seen in the prevalence of mental health challenges, both in the veteran population, but in the general adult population more generally. And so is, I guess, somewhat not surprising given what we've seen. We were also interested in looking at the impacts or the effects in mental health diagnoses by combat status. Given the nature of military service since 9/11 with repeated and extended deployments, we thought it might be important to look at whether or not people screened positive for PTSD or depression based on their combat status. And interestingly, what we find here is that those that had served on at least one combat deployment, they're shown in the brighter purple bar, were more likely to screen positive for probable PTSD, but were less likely to screen positive for probable depression. In addition to those mental health challenges, we see that many veterans in this cohort also face physical health challenges. About 20% rated their health as fair or poor. And again, remember, this is a relatively young cohort. So compared to a similarly aged cohort of adults, this is relatively high. We would see this 20% rate more similar to a general adult population aged 55 to 64. So this is just suggesting that veterans are experiencing a heavy physical health burden more so than other people of their same age. We did also look at this by combat status, and interestingly, we didn't see any difference in the physical health challenges by combat status. The poor physical health is also bolstered by our results around disability. We see that over 60% reported being disabled fully or partially, and that the average disability rating was relatively high at 68.5%. I think what's striking here is the change since 2010. In the study in 2010, only about a third reported being disabled, and the average disability rating was also lower at 38%. This is consistent with sort of overall trends in disability that we've seen among the veteran population over this time frame. I think it reflects both an increase in the prevalence of disability, but may also reflect some changes in rules and definitions and policies around disability ratings. We also saw reasonably high rates of alcohol misuse in this population, where nearly 30% reported at least one binge drinking episode in the past month, and 10% reported frequent binge drinking, which is 5 episodes or more during the past month. And while these numbers are high, they actually are a little bit of a bright note that the numbers have gone down since the 2010 study, where 38% reported at least one binge drinking episode and 16% were frequent binge drinkers. We asked veterans about their experience with food insecurity and found that approximately a quarter said that they had worried at some point during the year about not having enough money for food. We were also interested in whether and how veterans were accessing care, and so we'll turn to those results now. So on whole, on a variety of markers of access, this cohort of new veterans is doing reasonably well. That they found that nearly all, 97%, indicated that they had some form of health insurance. 3/4 said they had access to health care through the VA. And 70% reported that they had a usual source of care, which is like a primary care physician or other provider that they have a relationship with and typically see for their care, which is often used as a marker of good access. But the question is, does that access actually translate into use? And so we focus first on mental health service use. And in the past year, about a third of the sample had accessed mental health services. And among those that had accessed services, the vast majority said they had seen a mental health specialist, like a psychiatrist or psychologist, for at least some of their mental health treatment. But there was still a large proportion, 36%, that had seen a non-specialist, like their primary care physician, for at least some portion of the mental health services that they used. We were also interested in looking at mental health service use among those that we think might have a likely need for it. So the folks that we had identified as screening positive for depression, PTSD, or who had expressed suicide ideation during the past year, we looked at their use of mental health services. And certainly the rates are higher here. We see almost 2/3 accessing services during the past year. But that does mean that up 35 to 40% of those folks that have a demonstrated need for mental health services were not actually using them. We wanted to get at that unmet need for services more directly in the survey. And so we asked veterans directly, did you have a need at some point during the past year for a mental health service or a physical health care service, but weren't able to get it? And what we found that on the physical health side, approximately 15% of the veterans surveyed reported an unmet need on their physical health care side. It was a bit higher for mental health care, with about 21% reporting this unmet need. We delved into sort of the reasons for those unmet needs, what kind of barriers the veterans were facing. On the physical health care side, the primary barriers that they reported were difficult access, that meaning inconvenient appointment times or inconvenient appointment locations. They reported a lack of support services needed to get to or be at the appointment, so that might be transportation or childcare or concern about leaving work and not being able to go at a particular time. Several also mentioned the high cost of care as being a barrier to their physical health care use. On the mental health care side, they did also report some difficult access issues about convenience of locations and so forth. But a lot of the things that they mentioned were more on sort of their own perception of the care and their demand for care. So they might have felt that they needed care, but they didn't get it because they perceived mental health care might be ineffective and it wasn't worth the time. Or there's a perceived stigma around mental health care, and they were concerned about what others might think if they went out and received treatment. And others reported that they were worried about some of the side effects associated with some of the medications, and that kept them from seeking services. So there's a range of different barriers here. Interestingly, this sort of unmet need for mental health care is about the same as what we saw in 2010. Some of the barriers have shifted a bit, and one that I think is notable is stigma. That is still a big issue in the 2024 sample, but it is less important or less of an issue than we saw in the 2010 sample. So maybe there has been some progress on that front. We also asked veterans about their experiences of care when they use services through the VA, whether that's at a VA facility or in community care provided by the VA. And the first set of questions we asked were really about sort of the process of getting care. So again, getting at some of those issues around access and logistical barriers. And we're reporting here the percent of respondents who reported always or most of the time that these things were true about the care they received. So were the personnel welcoming and helpful when they came in? Were the appointments available at convenient times and available within a reasonable time frame? And what you see here are relatively high marks across the board for these types of questions, and relatively similar responses across VA facilities and community care. The one area where we see a little bit of difference between the community care and VA facility care is on the right-hand side of the slide there with the convenient appointment times and reasonable time frame. So while still high at VA facilities, it was a bit higher in community care. Another set of questions that we asked was really about their experience of care with the actual provider. So what was actually happening during the appointments. And what we're reporting here is the percent of survey respondents that reported they were satisfied or very satisfied with these elements of their care. So, for example, their ability to get referrals for specialist care, that the doctor was clearly explaining their care options. They felt that they'd been treated respectfully and their privacy respected and so forth. And again, across the board, we're seeing relatively high marks for both VA facilities and community care, and very little difference between the two. We also wanted to know if veterans had a choice of where to go at no cost to them, and there were no sort of access or logistical barriers, where would they choose to go? And what they reported was really interesting, and I think important to note that their preferences were really very mixed. There were about a third that reported that they would prefer to get their care at a VA facility. There were about 60% that reported a community provider preference, with that breaking down with about 45% saying a community provider not associated with the VA or military, and 15% saying they preferred a community provider associated with the VA. So for those groups that reported a community provider, whether with the VA or not, we asked about their reasons for that preference. And you see a number of things here, but sort of the highest or most important reasons you see along the right-hand side of this slide, that there was easier to access, and they felt it was easier to get an appointment at a convenient time in community care. There were perceptions that the quality of care they were receiving was better within community care. And many of the people, almost 40%, reported that they had an existing relationship with a provider in the community that they wanted to maintain, and really found that that was an important reason for preferring to get their care in the community. We also see, though, over on the far left-hand side here, that there was not a small percentage that report their community provider preference preference is due to the fact that they'd had a prior negative experience with the VA. We also asked veterans about a series of different benefits that they may be eligible for. And the sort of general finding was that they thought the benefits sounded helpful, but much smaller proportions had actually used those benefits. So this is just an example of one of the benefits we asked about, housing assistance and loans. And we found that 46% of the veterans we asked said this was a helpful benefit, but only about 20% had actually said they used it. Now, that may not be that surprising. You might ask a veteran, then they say, yes, housing assistance and loans sounds helpful, but it's not something I need right now, so maybe I haven't used it. But it could also be a signal of an unmet need. There's a benefit that sounds helpful to me, but I don't know how to access or use it. And the next result, I think, sort of bolsters this unmet need explanation, at least to some extent. We asked veterans whether they knew about what benefits they were eligible for and where to get answers about them, and asked them to sort of say how much they agree with this statement. And what we found was that only about a quarter agreed that they know what benefits they are eligible for, and that's about the same percentage about how to get answers about their benefits. And so that means there's upwards of 3/4 of veterans that are disagreeing with that statement and say they do not have a good idea about what exactly they're eligible for or how to get information. So with that, we'll turn to some of the recommendations that flow from these results. So certainly, given the higher rates of mental health challenges, some of the unmet needs for mental health services that we've seen, continuing to expand access to veteran-competent mental health services is going to be critical. That may be through increasing training of community providers in sort of culturally competent, veteran-competent healthcare services. It may mean focusing some on the demand side and trying to address some of those perceptions about mental health care and its ineffectiveness or the stigma associated with it, so that veterans feel more comfortable trying to go out and access that care. It might mean also trying to ensure that services are available in easy to access locations, whether that's in a primary care setting or through community-based organizations and so forth. Also, given the rates of suicide ideation that we saw in this population, continuing to fund and operate veteran-specific suicide prevention programs is going to be really important. Continuing to get new data and information about the drivers of suicide risk so that better and more veteran-specific prevention programs can be developed and evaluated so that they can be tailored and veteran-specific population. We also saw that veterans' preferences for where to get treatment is mixed, that many preferred to go to the VA, many preferred to go to community-based healthcare services, and many go to both. And so trying to maintain or access to both VA facilities as well as community care is going to be important so that veterans can really choose the type of care that's going to be most beneficial to them. Also saw that there were a lot of logistical barriers around getting to appointments for transportation or maybe a need for childcare or more appointments at convenient times so you don't have to miss work, and continuing to try to tackle some of those logistical barriers is going to be important. And finally, I'm sure many of you feel that you do lots and lots of outreach. And so saying increasing outreach and awareness about veterans' benefits and services is going to be important. But I think that last finding, where only about 24% agreed that they knew what benefits they were eligible for and where to get information about them, just reiterates that continued outreach, potentially focusing on some of the challenges and services that are aimed towards those challenges that we identified here, whether that's mental health care or food insecurity or suicide prevention. Additional outreach is probably warranted. And then finally, mirroring the overall change in the veteran population, becoming more diverse, more women, more people of color, that all policies and programs need to be taking that into consideration and thinking about what they do and how they do it and how to meet the needs of this changing group. So with that, I think taking these types of changes to policy, trying to address the challenges that we have identified, will really serve to improve the health and well-being of New York's newest veterans. Thank you.
For the both of you. Thank you.
Hey, thanks so much, Jeannie. I mean, that was a lot of numbers, a lot of facts. So we're going to slow it down and try to go deeper on some of that and give you a little breath. Okay? So in no particular order, for me, definitely a headline was the disability findings. I'm still kind of shocked, to see the incredibly high prevalence of disability, to see that disability rates had essentially doubled since our prior assessment. I know a little bit of that is definitional, has changed, and yet I don't think that can really explain, 100% increase in the prevalence of disability. Can you talk to us about that some?
Well, I think it's hard to say from our study what actually drives that difference between 2010 and 2024. But I do think, as you said, that it's both a combination of sort of changes in rules and policies and definitions that made it more likely to get a disability rating and potentially a higher rating than in 2010. And that does mirror what we've seen at sort of national level of higher rates. But it also must reflect, a change in prevalence as well. We know that, again, the nature of service since 9/11 has included more deployments, extended deployments, and so forth, and there may be some association there.
And when you talk about disability, this is an all-encompassing definition, right? So it is physical disabilities as well as what we sometimes call the invisible wounds.
Absolutely, yes, it is what we asked was whether or not they had ever been rated as disabled by the military or the VA, and so that would include all of those. Yep.
Is there, in terms of physical disabilities, is there a bit of a cruel irony that advances in battlefield medicine have made fairly grievous injuries that may have been life-ending in the past? They are survivable, but people can come home with serious disabilities as a result?
Yeah, I think that makes a lot of sense. Again, our study doesn't really speak to that, so I don't know for sure, but that seems like a reasonable explanation that people are coming home with greater injuries. Although, as I said, we didn't see a lot of difference looking at some of the physical health challenges by deployment status. So it does seem that, some of it may be related to deployments, but some of it may also just be related to sort of the physical health challenges of being in the military.
And what does it mean? So I think the average disability rating was about 2/3 disabled. For those of us more in the civilian world, what does that mean to be 2/3 disabled? Can you carry out activities of daily living? Can you work? What does that mean?
Be honest, I'm not really sure. I'm not an expert in the disability ratings and what that means, but that may be a good question for some of our panelists in the next session.
We'll come back to that then. All right, so mental health also, right? Probable depression up, probable PTSD up. You briefly said, this seems to align with basic national trends, other than, when you say national trends among veterans or trends across the general population?
We've seen increases across both, sort of the general adult population as well as other veteran populations.
Okay. And there was something in those findings that felt counterintuitive, at least to me, right? Those who had been deployed were more likely to have a probable PTSD diagnosis. That would seem to make
Right.
sense. But a probable diagnosis of depression was actually more common among those who had not been deployed, right? And I found that somewhat counterintuitive. Could you explain that?
Yeah, that's a good question. I found it a little counterintuitive as well. And, in discussions that we had about this finding, I think one potential explanation is that, perhaps the depression might predate some of their deployment. And so people that have depression may be less likely to be deployed in some cases. And so, or those that haven't been deployed may not have that sort of, it's a really interesting question, but it definitely is, I'm not really sure what drives that.
You did say this generation of vets, many had done multiple deployments.
Absolutely.
Was there a correlation in the data between those with multiple deployments, thus being more likely to have these diagnoses?
We did see, particularly on PTSD, we looked at it broken down across a number of different, no deployments, sort of like 1 to 3, and then, 4 or more. And the ones that had more deployments were definitely more likely to have had PTSD. The depression results were sort of a little bit more mixed, and so a little bit harder to sort of figure out exactly what the story is there.
A silver lining, if you will, was, we did, on the mental health picture was a decrease in stigma associated with
Yes.
mental health. Any thoughts on that?
Yeah, I think that, again, our study doesn't really speak to it directly, but I think, as we all know, there have been wide efforts, concerted efforts to really address stigma, both within sort of the general population and specifically in the veteran population. We see in a lot of sort of social media campaigns, public service campaigns, celebrities talking about their mental health challenges, making it more sort of acceptable to talk about and seek treatment for. So I think that's a possibility in what we're seeing there in the change in stigma.
I want to spend some time on this dynamic of community care and VA care, because that was actually one of the main themes that we took from our first assessment. And what we found was that veterans are just like everybody else. They like choices, and particularly in the Trump administration, there was an inside the Beltway debate about the privatization of the VA and so on. And that debate felt to us completely disconnected from the actual experiences of veterans, and that was a false choice. That veterans over and over and over again, and this time too, said, we want both. We want a high quality, accessible VA, and we want community-based care options. And many of us, mix and match. I use the VA for certain things, and I use community care for other things. And the reasons were not ideological, as in DC. They were often very practical,
Sure.
like travel times. I mean, if you live up in the North Country where Jordanna does, it's hours to get to the Albany VA center, right? So, anything different in this assessment, or those same desires for choice, remain just as steadfast 14 years later?
Yeah, I think that's exactly what we saw, was a very mixed preferences. We asked folks about their specific preference for, if they could go anywhere, and we saw that was mixed. But just in their demonstrated behavior, we had some people that had accessed care through the VA. They'd also accessed care through community care, and were reporting on their experiences with both of those. So I think it's really clear that they, as you say, sort of use the VA for some things. They may use community care for others, and it really just depends on the specific service and types of things they're looking for. One thing we did find, we asked about how much people agreed with a statement that their provider really understood the challenges that veterans face. And that was one thing that was which was definitely higher in providers at VA facilities. People agreed that they really did understand veteran needs more so than their community providers did.
Now, that was not a surprise to me, because some other work that we had done with RAND, we surveyed civilian community-based providers. I think the study was called Ready or Not, and that's on our website as well. And, that actually found, a pretty poor state of readiness among civilian providers to understand and treat veterans.
Yep.
There were kind of various thresholds to be fully competent, starting with the most basic, like, do you screen for veteran status? And many said no, much less having any kind of training or familiarity with veteran culture and so on. We also know that how you ask that question is vastly important. Like asking about veteran status and how you phrase the question can yield very different results. So that study told us they're not ready. This study says those who use civilian providers say they're awfully good. So help reconcile this.
Yeah, well, they say they're good, and various markers of sort of the experience of care that they have. But when we did ask directly about whether they were really understanding veterans' challenges, the community care providers did score worse than VA providers. So I think those things are in line. There's still a reasonable demand by the veterans to use community care for a variety of reasons, primarily around sort of convenience and access and ability to get specialist referrals and those sorts of things that may be more difficult.
What I think I recall was convenience and access for sure. I think many veterans said they didn't want their care to be fragmented. They wanted to go where their spouse, their partner, where their kids go. They wanted to be treated as a family unit. And some of the mixing and matching depended on the type of care. Like they specifically did not want to present to the VA for a behavioral health issue, for example. And is that still holds up as well?
Yeah, we didn't look at the types of services and whether which they were going to VA versus community care, but that is consistent with the types of things we've seen and heard over time, for sure.
I can't avoid the topic of veteran suicide. So we are fortunate that here in New York State, we use the phrase, we are less bad. Like veteran suicide rates, and in fact suicide rates in general in New York, are not as bad as national numbers, but they're not good. Veteran suicide rates are still twice that of civilian suicide rates in New York State. So dig deeper on the suicide-related questions and the assessment and what we've learned.
Yeah, so what we learned, or we asked a series of 3 questions asking folks about whether or not they had thought about committing suicide in the past year. And then among those, whether they had made an attempt, and that was about 11% had made, not whether they had made plans, about 11% had made plans to commit suicide, and it was a little under 1% that had actually made an attempt. So these numbers are, they sound sort of low in some way, compared to some of the other numbers that we were looking at, but given the seriousness of the problem, those are actually very high numbers. And as you said, much higher than sort of the general population. And so there's really an important need to sort of focus on veteran-specific prevention of suicide.
Rand does so much research related to military and veteran issues, across that whole body of work. Have you and colleagues at Rand, identified, let's say, best practices in veteran suicide prevention? What works?
Right. Well, that's unfortunately not my specific area of focus, but there definitely so I can't really speak to exactly what those best practices are, but there are there has been a lot of research, both by my colleagues and others, at other organizations about veteran suicide and some of the practices. So I'm sorry, I can't say more exactly what those are, but there are a lot of resources out there and a lot of work that has been done.
Or maybe our next panel will pick that up
Yeah.
too, because in the foundation's work, there's all the typical things you would expect, like mental health resources and hotlines and all of that, but we've kind of moved upstream, if you will, really into firearm safety, less access to lethal means, and moving into that direction versus just crisis intervention and so on. Okay. What surprised you? I kind of started with the disability stuff.
And I think you stole my thunder there, because that really is I think one of the most surprising results. And it's not that, part of it is just that it's a high rate, but it's the change since 2010. And because most of the variation we saw between the 2010 and our 2024 study, we're moving a few percentage points, not, up or down, not doubling as we saw on the disability side. So there's definitely something there. And I think that's probably worth some further study to really understand what's driving that difference. As I said, we didn't have, in the questions we were asking veterans in this analysis, a way to really understand what was driving it. But I think that would be something worth doing more work on and trying to really understand that huge increase since 2010.
Just a couple more to wrap up. You pretty much you started saying this generation of veterans is a lot more diverse, racially, gender, and so on. Were there any, patterns, or subpopulations where you saw differences in the findings?
Yeah, we didn't do a lot of sort of subgroup analyses just because some of the groups get, somewhat small. But in particular, one area where we did sort of look at different subgroups of the population was in their preferences for the VA care or community care, because we wondered if different populations might have different preferences as well as sort of different reasons for those preferences. So we looked at differences by gender. We looked at differences by urban and rural status, thinking some of those differences. And interestingly, we really didn't find many striking differences across the subgroups that we were looking at.
And maybe that's good.
Right.
I think women welcome
Exactly.
place in a
Yeah.
VA facility. Health,
Yeah.
like for so long. Place for a female that
Yeah.
saying they were equally.
Yeah, and that is exactly what I had expected to see, was that perhaps there might be a greater preference for community care among women veterans versus male veterans, and we really just didn't see that materialize in great effect.
What do you wish we had asked that we didn't?
Yeah, that's a good question. With a survey, it is always so hard. You have to really keep it short so that people will answer all the questions, but there's so much more you want to know. And I think what I would have liked to have been able to ask were more sort of broaden out beyond sort of health and healthcare to some of the social determinants of health, and if or look around education and employment and housing, but then be able to sort of see some of the interactions and interplay between those and the health outcomes. But unfortunately, yeah, we just really didn't have room for all of that in the survey.
All right, I'm going to wrap with the sort of broader questions, right? So we have an election less than 1 month away. I don't think veterans issues have gotten a ton of attention on the campaign trail. And I'm definitely not going to ask you to predict the outcome of the election. But I would ask you, what do you think is on the horizon? Regardless of who wins the election, what do you think the most pressing veteran health, veteran policy issues are going to be in Washington?
That's a really good question. I wish I knew exactly the answer to that. But I thought I guess what I would hope is that really would focus on, this sort of ongoing debate about privatizing the VA and sort of not having VA facilities or just community care. And I think, the findings here and what you'd seen, prior to this, that they both serve a really important purpose, that there are needs for VA facilities, there are needs for community care to improve access and different types of services, and that hopefully sort of working to maintain that choice and access to both types of care is going to be the way to best serve the needs of veterans. And so I would hope that's what people are going to be focusing on, rather than sort of arguing about whether it should be privatized or not, ways to sort of move forward with both systems and keep them both.
Great. We're going to leave it there
All right.
for now.
Thank you so much.
Thank you again, Jeanne.
Moving to New York, transition out of the military, and it's really wild to look at what was going on then and to kind of come full circle and be able to work with this amazing team to help this next generation of veterans that are serving. So it's truly an honor to be here with you all today. We're going to get things kicked off. You have our panelists' info on the QR code station. I think, Jacob, I'd love to start with you. So one thing in particular, there's so much that connects the veteran community. We have so many things in common. I can meet a World War II veteran, a Korean War vet, and we're going to have a lot in common. But we're also going to have so many different experiences that just, almost incomprehensible. But one thing that we have in common is the transition. And as you've heard from the report, most veterans transition back into civilian life and have a good go of it and get back to serving their communities and are productive members of society. But there's a lot that can happen. For me, I transitioned out at the end of 2008. The market had just crashed. It was not a great time to be looking for a job, but I had the new GI Bill to go to school. So I had some things that helped kind of weather that storm. And I also had a little bit of a runway. I knew my transition was coming. I went to TAP and TAMPS. I had a little bit of a heads up to know when I was going to be leaving the military. And that's not the case for everyone. Jacob, you were medically discharged. So I'd love to hear how that impacted your transition. What was it like having to suddenly realize that you're transitioning, and what was that first kind of transition period like for you?
Yeah, great question. Can everyone hear me okay? All right, great. So yeah, my transition was kind of unexpected. I was only in the Air Force for around 3 years total, and in my second year, I suffered a foot injury. It's not like a glamorous story. I wasn't in battle or anything. I just tripped and fell and broke my foot, and I needed surgery. But my surgery was delayed a couple months, so then my recovery was delayed much longer. And I was discharged through the newer program, the IDES program. I don't know what it stands for off the top of my head, but it's a good transition because you get your VA benefits set up before you actually finish your discharge in the military, so it's a more seamless transition. But going back to the root of your question, where I thought I was going to do a whole career. I dropped out of college to join the military. I thought I'd finish my bachelor's degree, maybe commission, maybe, I was planning on making a whole career out of it. And now suddenly that's gone and I'm broken, like my foot's broken. I can barely walk. Like I was a runner before that. Like I'm trying to figure out my new identity as I transition and focus on my recovery. And, now I go to law school. I'm graduating in December. Can't come soon enough. Thank you. But none of that was on my mind at the time, right? My recovery was what my focus was on, and so I wasn't thinking about benefits. And you mentioned TAPS, and I went through TAPS and all of that, and they're throwing all this information at me, but like I don't care about any of it. I'm not listening to any of it. I'm not absorbing any of it. I'm focused on, getting my body healed and getting my mind right, getting myself back home, So yeah, no, it was, I hope that answers the question.
Yeah, no, absolutely. I really appreciate that. And I think no transition story is the same, but they all rhyme. There's so many things that are common. But again, there's all these variants as well. Gavin, I'd love to kind of ask you the same question because you had a very similar story, but could you tell us how your transition was similar in ways that it wasn't?
Yeah, absolutely. And hello, everybody. It's good to see everyone. My transition, I'll say, wasn't as pleasant as yours. Air Force veteran. I went in wanting a career. Like, that was like my ultimate goal. 20 years, get out, become a police officer, and become mayor of my town. Those three steps was like what I was going to do. And in the middle of my first year, I actually got out after 1 year of service, but I repeat this all the time. I said I was part of the 1% of folks that was given medication in the service, and unfortunately caused adverse effects where I live to this day, where it's been 21 years now. Last year was 20 years of me thinking back, wow, 20 years, I would have been retiring that year, but I have seizures, headaches, migraines, back pain because they screwed up a procedure in the Air Force, depression. I have a whole bunch of stuff. I live with pain day to day. One of the biggest things for me when I was transitioning out was I wanted to take my life because I didn't want to live with pain, and I didn't want to wake up every day with my headaches, which wakes me up every day. It's like a challenge for me, which is something that I have to take a leave. I have to take sumatriptan injection when it gets really bad. That's been my transition after service. So the past 21 years, that's how I've been living day to day, where it's just severe pain. And I felt abandoned when I was leaving the service because I was like, listen, I could do my job. I might have these ailments, but I could absolutely do my job. Whatever you tell me to do, I will absolutely do it. I'll give my life for this country. What do you need me to do to make sure I stay here? So I fought the board to stay in the service, and then some medical issue happened when I was there, and they said, no, you got to get out. So when I was leaving, I threw away all my uniforms. I said, screw you guys. If you don't want, to at least give me a chance, I don't want anything to do with the military. So for several years, I actually had to live with trying to figure out if I'll actually take my life or if I want to go and get a degree, have a job. So for my years of after service, it was like the most difficult thing that I had to experience. And I'll say the hardest thing for me was definitely, and I hate to harp on it, but it was definitely suicide. That was one thing that still lives up with me today. And I shared with you yesterday, Derek, was in March of this year, I was actually going to take my life because I really didn't want to deal with the pain anymore. Like, it was so bad to the point where I was putting on my clothes, getting my keys, and trying to figure what I will do when I left the house, because I didn't want my wife to go to the same route that I take. I didn't want my kids to know what was going to happen. So that whole transition after service has been, I'll say, one of the most difficult things for myself. And I still live with it today, where I'm trying to figure out, did I make the right decision going into service? But I love the military. I'll absolutely tell everyone, the experience that I experienced is not going to be the same. But, definitely go in there being educated and knowing that if you do come out the way that you don't expect to come out, be prepared for all the challenges that you're going to experience, because the VA will deny you, because it took me 10 years to get my VA service connection. But they will definitely battle you, when, I won't say the VA, but the individuals that have to look at your claim will deny you based on just words that you don't know what to say when they ask you the questions. So for me, it was absolutely difficult.
First, I just truly appreciate your candor and you being here with us, your bravery for telling your story. I know it's something that's very difficult, but there's so many folks out there that can relate. Myself, having suicide ideation in the past, pretty much any service member out there has been something that we've been afflicted by. So I really appreciate that. And I think, thank you. Absolutely. And clearly, I'm so glad that you're here with us today and continuing to serve so many others. Really appreciate that. I think there's a lot that you touched on there. I think this idea of like loss, identity, TAP and TAMS doesn't tell you how to have a purpose after the military. It doesn't tell you how to deal with grieving or dealing whatever you dealt with in the military. But also, we're talking about transition as if it's like, one thing that ends. You talked about you've been transitioning over a few decades now. I kind of feel the same, to be honest. Jordanna, I'd like to turn it over to you, though, because I think when we're talking about Guard, Reserve, there's almost like a few transitions. There's a soft transition. You're kind of serving your community, now you're serving abroad. What does transition mean to you and other folks that have served with you in the Guard or Reserve?
So I think transition in the National Guard or the Army, in my case, Army, but in the reserves, can look a couple of different ways, right? So there's the overseas deployment that you come back from and you return to your family and to your job and to the kids and the dog and, whatever else is there. And all of that support and all the people, the people that your entire world revolved around for 365 or, 18 months, they're gone. And now you're back in this place. And I always, when I think about it, it always seemed like, if you're traveling along this path with you and everybody in your community, and then you go over here and you're on your deployment and you continue to come back, right? You want to go back here because that's how you remember things being when you left, except everybody else is up here now. That's where the rub sort of lies. So I think that for me, my transition from Afghanistan in 2010, I interviewed for a job while I was overseas, and I thought it was going to be a great fit, and they, said that they wanted to hire me. And I think a red flag should have been when I said to them, well, I'm going to have 30 days of terminal leave, and then I want to start work. And they're like, well, we'd really like you to start earlier than that. And that to me should have been an indication that although they said they wanted a veteran, they said they wanted someone with combat experience, they really weren't willing to change their plan to say, so I ended, I was back in an office, and it was like 23 days after I left, an air base in Afghanistan. And that is not a recipe for success, which might seem obvious to all of you sitting here, but it was not at the time for me. And so I think that transition was a lot of lessons learned for me. When I returned from Kosovo in 2002, I knew enough to put in some benchmarks to say I'm coming home on this date, there's nothing. And, family wanted this, wanted that. I said, I want 2 weeks of nothing. I need 2 weeks of a clear calendar for me and for my family and for my daughter and for me to drink Starbucks and sleep late and, whatever. But so it was a little bit of a lesson learned. And I think we get back, right, the more often we do it, the better we get at it. And I think the reality for a lot of National Guard soldiers and Reserve soldiers is that it's not just once, right? Just the way the operational tempo has been. I think it's really difficult. I'm going on 23 years now of military service. I think it's really hard to find someone that's been in for that long that has one or no deployments in the Reserves or National Guard. It just doesn't exist, just the way that things have been going. So I don't know if that, so then now I am looking. I tried to put in my retirement packet and I joke that I completely failed. Well, I'm not joking. I totally failed at trying to retire from the military. My chain of command had other ideas. And I did, after an accident, end up, now I'm going through this medical discharge process. So as a National Guard soldier going through the medical discharge process, it is, we were talking about it last night, it is like a comedy of errors, I have a full-time job, I have things that I'm doing, but then they call and they say, well, you need to be at this appointment. And I say, well, I have a job. I can't just drop everything. And the contract says it's got to be 30 days. And so, and by the way, the location that the VA has a contract for you to go get this appointment is 2.5 hours away from your house. And there's this big lake called Lake Champlain in between you in New York and the address in Vermont that they're adamant is 42 miles away, says someone in Indiana sitting behind a computer screen. And you're like, I can't make this up, right? Like, I can't make this up, that I literally have to explain to someone that there's a lake between me and the audio doctor. Like, I can't get there. Like, yeah. So I'm trying to maintain my sense of humor. I think a lot of times I say to myself, like, I have flexibility, right? I have a car. I have a reliable car. I have plenty of money to put gas in it. I'm a native speaker of English. I'm college educated. If I'm struggling with this process, like, I have an amazing husband who, will do anything for me to support and assist me. How would a National Guard soldier who doesn't have any one of those things, now trying to, like, medically discharge from the military in a civilian setting, like, I can only imagine what their struggles must be.
No, absolutely. Thank you so much for that insightful comment. I think that also just kind of continues this theme that there's so much that we all share, but all those stories are very different, and our times in service have impacted us in a lot of different ways. I think similarly, when we're talking about healthcare access, it's something that we're all going to have to deal with at one point. And I think building off the RAND study and looking at regular sources of care for veterans, that's one thing I've found like shockingly common. When you're in the military, you have that person that says, here's sick bay, here's where you go. Like, it's all lined up. And you get used to it. Yeah, absolutely. And then you realize it's the exact opposite once you get out of the military. And it wasn't until I started working at the foundation 8 years ago, because I was an independent contractor prior to that, I didn't have a regular source of care, because I would go to VA in Manhattan, but it's a teaching hospital. So you had a different doctor pretty much every year. So it wasn't regular, and that was an anomaly. But that was kind of my experience navigating healthcare. And it's so nice to have a primary care doctor where you don't have to explain certain things to, or they have your records. And I found that a novel approach to healthcare in my early 30s. So Jacob, you had mentioned this. You had kind of started with VA benefits prior to transitioning. And I'll ask all of you this, but to start off, what was navigating healthcare like for you, and what were some things that worked and didn't work for you?
Yeah, so I would just like to echo, it is very frustrating when you feel like you have insider knowledge and you're still running into roadblocks. Like, I'm an accredited VSO, I'm in law school, and I still get VA denials for care sometimes. And so I actually did want to share a story about that, because it happened over the summer. I have special eligibility for dental. So if you've been in the VA system at all, dental isn't always covered. You have to have special eligibility because the VA doesn't consider it part of your health care, which is a whole nother issue. But so I had the special eligibility since I'm in Chapter 31 for VA for my schooling. And I had a split tooth impacting a nerve. I needed a root canal. And I live here in East Greenbush. I go to VA Stratton. They have dental facility there, but they don't do root canals there. So they had to send me to community care. The closest they had was in Kingston, like over an hour and a half away. And so it's like, even when you are at a location that has the facilities, you still will get sent out sometimes. And then the driving and the distance and all that factors into it. I would say, like, my experience with my primary care physician has been fine. That soured our relationship a little bit, because I had told her about my special eligibility when she put in the referral, but it had to come from someone else completely, like on the education side of the house, which didn't make any sense to me. If I'm at my doctor and I'm telling them I'm having an issue and I'm telling them I have eligibility, why does it need to come from a specific person who's not my doctor for a medical referral? So it's the frustration is very valid, especially from advocates who are well versed in the issues. They still run into issues with their own care. That's what's happened to me. Yeah, so I would just say it's mixed. Like, I do think it's good to have veterans using VA healthcare. It was really interesting to see that they prefer the choice. I agree with that. I do think it's important to have meaningful choice, because we see with the AMA, with VA changing, when you want to appeal, you now have a lane you get to choose, and veterans now have all this choice with how they seek appeals. But also, if only 25% of veterans are aware of where to go to find if they're eligible or not, I mean, is the choice really meaningful if they're missing the relevant information they need to make an informed choice? So I think that's just important to context there. But yeah, I would say VA healthcare is mixed. It's better than nothing. We should get veterans involved, but we shouldn't expect perfection because it's far from.
Yeah, no, I appreciate that. Jordanna, kind of same question. What's navigating healthcare kind of look like you as a member of the Guard?
So I buy into TRICARE Reserve Select, which is an incredible health insurance program compared to what's available in the civilian sector, and a huge benefit of serving in the National Guard or Reserves. So my care has really been a hybrid of the two. When I came back from 2010, I was one of the, 600,000 with lung issues. And I went to my primary care doctor, and I live in rural upstate New York, about 3 hours north of here. So if you go to the emergency room, you're seeing a PA. And I was trying, and I wasn't getting anywhere. So I said, all right, I need to go see a pulmonologist. And I put in a request through the VA, and I put in a request through the civilian sector. And I said, whoever can get me an appointment first, that's where I'm going to show up. I mean, it was no more scientific than that. And the VA in Albany I was able to get an appointment there. I saw the pulmonologist, and he was like, yep. He changed this, and he's like, that's how we treated this 10 years ago. Where have you been going for your medical care? And I thought, well, I went to the urgent care clinic in rural upstate New York, and that's what the PA gave me. So he changed my medication, and he said, in about a week, you'll know whether or not this is the right thing. And I remember the run, to this day. It was like, I went running in Henry's Woods, which, if you're familiar with Lake Placid, New York, is a trail network. And it just felt good for the first time in over a year. And I was like, oh my gosh, great. I hit the jackpot, from what I understand, because if I had gone to that civilian pulmonologist, I have no idea, what my experience would be. And so that continued to be a really positive experience for me. I didn't change my women's health. Every month I would get a call from the VA. You're overdue for your female exams. And I'd say, yep, I took care of those with my person that I like to see. And they said, well, you're interested in changing. I said, no, I'm not. But that's not reflective on the VA. I don't know how many women optionally choose to change their lady doctor, right? That's your person. So I don't see that necessarily as being reflective on the VA, right? We don't want to change. And I think that was referenced in the report as well, that you want that consistency of care. So I think having that choice also, I feel like, gives veterans back a level of power and control that they haven't had, right? When you're in the military, you don't get to choose which pulmonologist you go to. You don't get to choose what doctor you go to. And I think that having that, although at times it is overwhelming, is important in a veteran taking responsibility for their care and managing their own care.
Yeah, I appreciate that. And Gavin, I'm going to tee you up for something, though, because I think you touched on something that's really important here. I think the idea of choice and what that matters to us in regards to our healthcare options. We were having this discussion about finding the right therapist. And I'm just such a huge mental health advocate, been in therapy for 13 years, tried every modality, and very much support it. But I feel like I got lucky the first time I did an intake. I started with the Headstrong Project, if you're not familiar, great organization. And when I did the intake, I vibed with the intake person, but they're like, but I'm not the person who will provide therapy. I was like, no, we just hit it off. Come on. And then I was like, that's fine. It's going to be tough, whatever, I'll do it. And then I got connected with my therapist that I was, with for over a decade, and we vibed as well. And I was like, thank God, this is just so nice. But that's not super common. So when we're talking about, mental health care, how important is it or how difficult is it to navigate, and how important is it to find someone that you gel with?
Yeah, absolutely, and I'm glad you pointed this out, because we did have a conversation about this yesterday. For me, I'm from Jamaica, and my upbringing was not to talk about what was happening. That whole conversation about mental health, about whatever you're experiencing, that was not part of my family dynamic. So when it was finally something that I was like, okay, maybe I do need to start getting help for. My mental health is wonky. All the stuff that's happened in my relationship with my wife, is deteriorating. I need to go get help. And this was actually after I was able to finally get my claim for the VA. So this was 2 years after getting the claim. And I was like, all right, great, I'm going to go to the Bronx VA. And I was like, okay, great. Walking in, I'm going to share what has happened to me in the service. I tell them that what I'm experiencing for the past 10 years of not receiving like the care that I thought I should be receiving. Like I said, I'm going to be very open because I want to deal and address what's affecting me at this moment. And I didn't realize it was going to be a 6th session with the person, but they said at the last session, and this is, and I've shared this a few times, but I can't quote it, but they said that they didn't think that I was going to be needing more mental health services. And I looked at them like, okay, I guess everything that I just shared, the fact that I was open doesn't qualify me to at least go beyond the care that I'm looking for. And that was the first step of me realizing and thinking that, dag, this really is a really bad decision of me even opening up and talking to people. So I've actually made that perception every single person I've seen after that first impression, that every time they saw me, it was not going to be what I wanted. It was rather what they were thinking that I would need. And every time I went to the therapist, or every time I went to see somebody, I always look at them and I'm like, okay, how long am I going to be speaking to you, and where is this going to be going? Like in the back of my head, that's all I was thinking. How long is this going, and how much am I going to get out of this? And am I just going to be coming here just to check the box for the VA so I can continue to receive my services, like my benefits and everything? And then eventually I decided, like, I don't think I want to go to see a therapist anymore. But then I was like, okay, you know something? What do I need? I want to see a Black therapist that I could connect with, because I'm dealing with stuff that I know some people are not going to be able to understand. So when I was making that decision, I was told that there are no Black therapists at that VA. And then the therapist that was actually leaving, they said that, okay, let me look into this. Let me check and see if there are any. And as I knew that they were looking, in the back of my head, I'm like, if they don't find anybody, this is the last time I ever come to the VA. Like, screw you guys. If you're not going to have somebody that I specifically want because I want them to understand what I'm experiencing, then I'm not going to be here. Then what's the sense of me even talking or even looking for care if you're not going to even address what I want at that moment? And eventually they did find someone. He's the only one there at the Hudson Valley VA. And I was like, wow, the amount of thousands of veterans that go to the VA, there's only one Black male therapist that only sees Black veterans on a Friday. I'm like, okay, well, if that's the best they could do, I'm going to accept it, because they actually did, meet my request. But then I also think that, wow, what happens if so many of us, do need that specific person that is going to be able to understand us at that moment? What if I say, okay, I want a Jamaican Black therapist? Like, what if I start going into real detail, specifics for what I do want? And I think that's, and I don't blame the VA or anything like that, but I just say that, those are things that for us as individuals that are looking for care, it's not always what the VA thinks is best. It's what we want as individuals, because, one thing that that really did help me when I actually did have this Black therapist was my son was bullied on a school bus, and we all know why. That's something that I saw, and I was like, who the hell am I going to talk to about this? My 5-year-old son that just started going to school for kindergarten is getting bullied and picked on right now. And for me, talking to somebody at that moment was really helpful, because my mind was like, all right, my reaction as a father, as someone that has to deal with this, with a son that is just loving and compassionate, and say that he's not going to hit anybody because he loves everybody, and I'm going to have to tell him why someone's going to hate him because of skin color of his hair, like all those different stuff. Talking to somebody that was able to say that they understood and they had to talk to their children made me feel better, because I was like, all right, thank you for sharing that. Like, what did you go through, and how did that help you? Because for me, this is going to impact me I'm still thinking about it. And for my son, he don't even care, but it's been several weeks now, and I'm still trying to figure out how to really come to terms of like what has happened to my 5-year-old son, and I have a 3-year-old and I have a 2-year-old. I have to, tell them that conversation. So having the right person that you have to speak to that could understand you at that moment is absolutely important, because for me, personally, if it wasn't available, I'm not sure how my mind would be just knowing, where it could have went.
Yeah, no, absolutely. Again, I just want to thank you again for your candor, everyone on the panel. This is really insightful conversation. And I would say one of the things that I love and hate about the military is it gives you a really good dose of what it means to be in a community where you have each other's back, you have shared goals, you have a lot of common themes, and you go back right into this individualized society where it's you and you don't have very similar I think experiences with a lot of folks, and that could be very isolating. But it is good to see also, as the study showed, the reduction in stigma, where folks like you all can talk about this, and someone might be tuning in online and think, oh, wow, I feel the same way. Maybe I will muster up the courage like Gavin did and seek out services. So it's really important to have these conversations, and I appreciate that. I think again, on a similar theme, when we're talking about navigating healthcare, another big component is just navigating benefits in general. And Jacob, want to turn it over to you because I find it interesting. Even though the community is great and you share a lot of information in the military, there's this Lance Corporal underground where everyone has they know everything, but you don't know where they're getting their information from. You get a ton of bad information. This is kind of something similar to you with education benefits. What was it like finding what you actually rated? And can you tell us about a path that you almost went down based off some bad information?
Sure, yeah. Yeah, so when I got out through the IDES process, medically discharged, and I was on my terminal leave at my parents' house, just kind of being a bum, chilling, I received a call from the VA that I had education benefits in the VRE, which is separate from the GI Bill, vocational readiness. They've changed the name recently, actually, but it's the same acronym, VRE. And so therefore recently separated disabled veterans, you receive transition benefits, and often it's in the form of education. And so that's how I've been able to go to law school. And then specifically on your point about the learning about eligibility to benefits, 2 summers ago, I was working with Benjamin Pomerantz as a legal intern, and he had me go through the Veteran Service Officer accreditation, and that's really when my eyes were open to all the benefits that are available and how to be eligible for them. Sorry, you were hinting at something specific you wanted me to talk about, which was that when they called me to talk about the education benefits, I thought I would maybe use them to get a paralegal certificate, but they told me that was, selling myself short, that if I wanted to be a lawyer one day, I should just go straight to law school since I already had my bachelor's degree, since I finished it online while I was in service. And so I was discrediting myself. I was selecting myself for less. I didn't think that I would be able to go to law school. And it is a lot of veterans have their self-doubt. They minimize the role that they played. I never deployed, so I felt like I didn't deserve all these benefits. And so I think a big part of the veteran advocacy is kind of waking a veteran up from that. You don't have to trust all the misinformation, disinformation from the barracks lawyers. You can actually, talk with someone who understands the real eligibility requirements and see if you meet them or not. It's a pro-veteran system, hypothetically. And so the benefit of the doubt is with the veteran. The legal standards, the burdens of proof are much lower than they are in other areas of the law. It really is getting the veterans accessing, feeling motivated to go and get involved with the process, and whether it's distrust of government or whether they're selling themselves short like I was. It's an individual conversation, I think, with each veteran, what is holding them back for accessing their benefits. But don't let the bias and stigma stop you. Actually talk to someone who knows the real rules for eligibility.
Yeah, it's great advice, and I appreciate that. Jordanna, I think kind of similarly, as a major in the U.S. Army National Guard, you're a leader. You're a leader regardless, but especially in that regard. And I'm wondering, what advice do you give troops or folks about navigating benefits or any of the experiences that you had so that they can learn from what you've been through? What does that look like for you?
So I talk about blue jeans, right? pretty much everyone in America has a pair of blue jeans in your closet. And we've all had that experience where you have to buy a new pair, which is oftentimes pretty traumatic, right? Because like the ones in your closet, they fit really good and they fit good. They're like, they're your jam, right? So you go out to buy blue jeans and you go to the store, whatever store, doesn't even matter which one, and you try on that first pair and you're like, these suck. Clearly, they're not like the ones in my closet, right? So you don't say to yourself, well, that's it. I'm never wearing blue jeans again. No, you try on a different pair. And it's like so simple, but I have probably repeated that scenario hundreds of times to my soldiers as they're transitioning out of the military, whether it's about finding a therapist, like, oh, didn't fit. It's not like you're not going to go, you still went back and tried on another pair of blue jeans. So you still need to go back and try on a different therapist. Or your benefits, like, okay, that one didn't work out. Well, you still got to figure out what does, whether it's working with a VSO or trying a different organization or a different VA hospital. So that's the lesson that I really, I try to instill in my soldiers when I'm talking to that. And I did want to just hit on something you said regarding like deserving. And last night we all had dinner. We keep referencing like last night. So we all sat around and kind of chat, like pre-gamed, for today. And I told this story. So, back to the pulmonologist, he tells me, this is related to your military service. You should probably submit for a disability. I'm like, okay, fill out all this paperwork. So now, by the time it's all said and done, we're like 3 years after the incident, it gets figured out. So by the time the VA sends me that check, and this is back when we used to get like actual legit paper checks, I get this check in the mail, and quite frankly, it was a bigger check than I'd ever seen in my entire life, I'll be honest, right? So I looked at it and I was like, well, that seems like an awful lot of money. Like, I probably don't deserve that. So I put it in the glove compartment of my car, this check, because I didn't really want to cash it and I didn't know what else to do. So I stuck it in the glove compartment of my car. Again, I can't really tell you that was like a rational or a logical decision, but at the time, it really seemed to make a lot of sense to me. And about a month or so later, I mentioned to someone that I was driving around with this check in my car. And she said, like, that's really dumb. Like, why haven't you, like, put it in a separate bank account if you don't want to touch it, or, like, at least put it in a safe deposit box, but, like, don't drive around. And I really like tried to think like, why am I doing this? And it went back to that sense of like, well, I don't know that I really like deserve this money. I'm taking this medication. It's good. I'm running. Like, there's veterans that haven't been able to return to service. There's veterans that have lung cancer. There's and I just thought about all of those worse off people than me. But I did eventually cash the check and it's all good now. But I think that same aspect like resonates. And when it talks about the benefits, one of the data points was about the accessing of benefits or not really knowing. I've got to imagine there might be an underlying sense of like, well, I don't really need those benefits, so I don't need to like find out what's going on because I'm doing okay. Like, veteran X is worse off than I am, and they need those benefits. Like, I don't want to waste them on me.
Yeah, no, for sure. I feel like that's another thing that I feel like is really useful in the military, where you're always taking care of someone who might need some help, which is also just good in life in general. But it's so many self-inflicted wounds afterwards where veterans feel like, oh, there's someone worse off. So I feel like that has to have a lot to do with the low utilization rates, because you ask veterans, they like these benefits. Absolutely. Are you going to use them? Like, absolutely not. And it's just like trying to figure that out. And I know that was instilled in us, where it's like, you always try to persevere. And I think, Gavin, for you, you're like, I would consider like one of the ultimate like peers. You do a lot of this peer work, just a great guy all around. And you talk to a lot of vets, connecting them with benefits. What's some advice that you give recently transitioned vets, especially from a more peer-to-peer component?
Yeah, absolutely. And I'll tell you, I did receive a check from the VA when they gave me my claim, and I actually had to go to my pastor because I was like, did I really deserve this as well? Like, when I received that, for me, it wasn't the money. I wanted the VA or the Air Force to acknowledge what happened to me in service. So nothing financial is going to change how I thought. I'd rather hear them or have a letter saying that we apologize or we're sorry for what has happened to you. We send our condolences for all the issues, like all the things that you would expect someone to apologize for. And that's what I was looking for. I was looking for that letter that just apologized and take onus of like what had happened. So when I did get the check as well, I was like, what is this for? Like, I don't want this. I want a letter to say why or what, what they happened. But for the veterans that I've actually talked to and connect with, the biggest challenge for them is wow, I think this topic could be in its own separate panel because the reserves and guards, like the folks that didn't get federally activated, those are individuals that are always looking to seek services. Like one story I could actually share is someone that served during the Vietnam War, and they weren't deployed to Vietnam. They were actually stateside, and they were a nurse, and they absolutely love what they did, but under the VA eyes, they don't qualify for VA services. So they, and this is, I've seen it many times where they actually started crying because they're like, I'm not recognized as a veteran because I was not federally deployed, but they did amazing work because the veterans that did come back during Vietnam saw that person to help them transition back into, civilian life. And for a lot of folks, when they do look to get benefits, they're like, what am I going to get out of it and how can I get it? It's like all these different multitudes of questions, like my service connection was if you're dishonorably discharged and you want to upgrade it. There's so many layers that you have to pick from that one person to what they're looking for. But a lot of them always go back to, they can't trust the VA or someone because they're like, okay, once this happened, like, what are they going to do to me? Because I've heard stories. So it's like for everybody, it's a whole individuality of finding like what they were looking for. Like, why are you going after this claim? What's going on now to where you want to go for the claim? Because we've worked with Vietnam vets and Korean War veterans where they haven't even looked into VA services. They're like looking into it now because of their health, looking into it now because of their financial issues, and they're like, listen, I need to take care of my family, so I want to address this because it could help me get financial, backing because of what's happening. So it's like so many multitudes of reasons to why the veteran will not, or I'm sorry, the veteran would go for a claim. But the biggest things I've seen most recently is definitely veterans not knowing that they actually qualify for benefits. Like veterans that are saying, hey, I didn't know I could actually go to the VA and apply for benefits. And that goes back to the information that's actually given to them when they come out, when they're transitioning out of service, and how much information is even given to them. And, like, are they listening? Are we even listening when someone's telling us like what's available to us, or are we more focused on what's happening at the moment? And that's where I think a lot of the information gets skewed, because a lot of us don't care about what the heck is on the other side. It's more of like what's happening right now for me to get to the other side. And then when we're on the other side, it's like, what am I supposed to do now? Like all that information, like once you sign the paper, you're completely cut off from the military, and now you have to figure it out. So all the information they're giving to your one side, you can't get back to it. So now you have to figure it out on the next side, and just get confused for us and overwhelming to where we finally figure out what we need and what we deserve years later, when we realize like, wow, I could have qualified for this. And so I think it's just information that can be given at that moment, right after and before when they come out.
Yeah, absolutely. And I think to the vets in the audience and tuning in online, if there's one takeaway, like cash those damn checks, I guess. Please cash those checks. But I think there's so much there, Gavin, that you touched on, I think is super important. I think generational divides that we're seeing a lot of now. And I think I always, to the Vietnam veterans out there, welcome home. You're some of my favorite people out there. There's so much that we do now that we would not be able to do. And I think VA being the powerhouse that it is, and I think this is really reflected in the report. I had not great experience at VA, but on the whole, I really enjoy it. We've all discussed this. Women in particular, there's a lot of sexual harassment at VAs is not very welcoming. To be clear, that's usually done by other veterans that are there. It's not like a VA thing happening. But what we're seeing is that VA on average is, trust is increasing at record levels currently. One of the best, healthcare providers out there in the nation, hands down. And I think this is what we're seeing about the veteran community. It's not black and white. It's not VA is great, so it's perfect for everyone, or these services are available, but people aren't using them. We're like learning how each of these little, kind of anecdotes paints a larger picture. So I really appreciate everyone chiming in with all this insight. Jacob, I think just kind of focusing it, retrospectively, what's something that you feel would have made your transition smoother if you could go back and change anything?
Well, I think everything happens for a reason, so I don't think I would change anything. But I think TAPS should be more like IDES. So I think instead of just being thrown information, it should be service members when they're in that 2-week period where they are transitioning, doing the courses or whatever. They should be put into the VA system then, I think would just make everything smoother. I wish they would have called me a little sooner for my education benefits so I could have applied to law school a little sooner. I wouldn't have had as long as a gap. That might have been nice, but I'm not complaining about that. Yeah, I don't know. I think everything happens for a reason. So like adversity is an opportunity to overcome struggling. And so I just am kind of a tragic optimist on that point. So I don't think I would change anything.
That's such a veteran response. Jordanna, same question. What's something that you would like to go back and maybe change to make things smoother for you?
Okay, so when you come home from a deployment with the National Guard, you go to a demob station, and you mob and demob out of, honestly, some of the worst Army bases that I think are out there. And they do that so that when you get overseas, it doesn't seem quite so bad. You're just relieved to have left wherever you came from. But I really believe, and other countries, this last assignment, I worked at a NATO headquarters, and I spent a lot of time with soldiers from other countries. I think they should send the soldiers home to their families for a week and then bring them back to demob. And then I think soldiers would be more focused. They would take the time to address their issues. They would really invest in the process. But I think at the demob station, all you're thinking about is trying to get home. And you're like, I don't want to say anything because they've got their little check sheet. And if you answer yes, and then you get segued and you've got to go over here, at that point, anything that's going to delay you getting to your family just becomes less of a priority, whether it's your mental health, whether it's your physical health, whether it's your financial health. And I really increasingly think that we need to look at the way that we demobilize soldiers from active duty with the National Guard and Reserves. And we need, even as a 4-day pass, I don't know, or fly all the families to where there's something that they can kind of do better in that process, and have like the mental and emotional like focus to actually look at all the resources and to process the information and to invest in their health.
Yeah, I appreciate it. Just a quick anecdote, just jogged my memory. I'll never forget this. When I got back from Iraq the first time, the gunnery sergeant had a mental health screener, and he said the answer's all no. That was it. I was told us that the answers are all no. And you just do what you're told. So like, all right, no, because that was standing between us and leave. So we're not going to take our mental health seriously, or we don't want to be that one person. It's like, well, actually, and signed out no, and then we turned it in and, went about our way, which is insane to think about. Gavin, similar question. What's something you would change to maybe make your transition smoother?
I'll definitely throw in the family. One of the big things that, as when I was transitioning out in 2003, was my mother, who reached out to, or actually the sergeant, I think I shared with you, the sergeant told my mother not to worry about me and that I was a man, so whatever was happening to me basically was, I'll deal with it. And I think for transitioning anyone, I think the family should be definitely like side by side with the person, because once they get out and they're going through their mental health challenges, the families that are part of that transition will know where to send their that family member, or also have something on the civilian side to when they are leaving and say, hey, listen, I'm going back to Texas and San Antonio, whatever, the family could reach out to somebody specifically there that's on the civilian side that says, well, listen, now that you're coming back, we know that you're, because we're not focused on transition out, but the families really are, the spouses, the where you're going to send your kids and everything. So they have everything, crossed off to make sure that, we're okay. But if the family member, I think, was part of the, either the on the parallel side of like the leading out of the service, and then when they get into the community, they actually get all the resources as well along with the veteran, because that would be a big thing, because we always say 9 times out of 10 it's the family members that are reaching out for help, that's calling our organizations, ClearPath, like all these organizations in New York State, family members are the ones calling us to say that this is what's happening to my the service member that just transitioned out. So if the family was a big component in that transition, I think it will absolutely make a difference with the person.
Yeah, I couldn't agree more. And I think looping in family is so important because it's rare that, any veteran goes through anything and they're not involved in some capacity. I think in some great ways, a lot of support and a lot of benefits to having them, but also the opposite. If they're not around, that can be very isolating and difficult. Just want to ask if folks have any audience questions. You pass up those cards. Just want to be sure that you'll have a chance to chime in. I think we were joking about this when some of us were ready to transition out of the military. The person who's telling you about the transition has not transitioned, but they're the one giving you advice. And it never even crossed my mind, like, how do you know what it's like being a civilian? Like, you're literally in uniform. Like, you've never been not in uniform. So for that reason, I've received a lot of bad advice. But conversely, have any of you got a good piece of advice when you were in the military that you felt really helped you, either with the transition or just in your time after service?
So there was one sergeant who, after I broke my foot and after I had my surgeries and I kind of saw the writing on the wall that I wasn't going to be able to stay in the military and kind of the beginning of the process, we were just out by the smoke pit and he was just telling me, how he lives with some regret that he wishes he would have either never joined or would have just done one term and got out and went to law school. And it was before I even had it on my radar, and something just kind of clicked in my brain, like, 10 years from now, I don't want to be that guy. I don't want to have that regret, So that just that was the kind of passive advice. And then, like exactly what you're saying, there are plenty of the people who have already made the decision that they're staying in and they're committed to it for their whole career, and they might not be as sympathetic to, your injury, and they want you to power through and try to stay in as much as you can. And for me, I wasn't going to fight the universe. So, that was the advice that stuck with me.
I don't really have anything so deep and meaningful. I feel like people said don't drink and drive, right? Don't stop doing PT. It won't go well for you. I think it's just more things like that. But I think overall, finding a good VSO that you feel comfortable working with, I think that is critical, right? If you haven't gone through IDES and you get out and now you need to navigate that VA process, having a partner to do that is essential.
Oh, wow. I guess my transition was so difficult that I didn't have that person to help me, but it was
peer,
yeah,
peer, if you will. Yeah, exactly. Mm-hmm.
But I'll say it's after service where I saw the community and the support of veterans, and where it was just where you had just about everything. For me personally, it's everything that what you could ask for was there. The community, when in my most difficult times, people are always saying, Gavin, make sure you reach out to me. I don't care what time it is, whatever it is. And that for me is really important just to hear, and sometimes it does get difficult to make those phone calls, but knowing that I can make a phone call at 2 or 3 o'clock in the morning, is really helpful. So I'll say,
Yeah, absolutely. No, I appreciate that. And guys, I said no big words. You guys are killing me here. No, but really great questions, and would love to get to a lot of these. They're really insightful based off of the study in particular. But just in particular, what can community care do better, the non-VA care, to better understand about providing care to vets? And I think this is one of the important things I think of this panel is actually asking veterans questions and listening to what their response is. Because if you've seen, the joke is you've seen one VA, you've seen one VA, you've talked to one veteran, you talked to one veteran. there's so much in common, but depending on race, gender, age, whether you deployed or not, these are all things that I feel like are not common in our healthcare system, where you sit down and listen and really understand what's going on and put forth the effort. There's a lot of great training out there, though, so I'd really recommend that for folks that are interested in learning more. And similarly, great question about, since there's this huge increase in disability rates, kind of what's the commonality? There are breakdowns from VA that you could look up. Hearing, I think disabled hearing is probably one of the top ones. And of course, I think this is something that I think we could all probably attest to. It should be obvious, but the tempo that we've been deployed for the last 20 years, even with like the withdrawal from Afghanistan and kind of like the end of combat in Iraq in 2010, it just puts a lot of wear and tear. So between mental health, physical health, and then we all know that just as Americans, like, it's tough out there, just doing your daily grind. So it really takes its toll on you, but I'll happily follow up with any of these.
I would just add that the PACT Act might have also been a reason for increase
100%.
because it was the largest expansion of eligibility benefits.
It's a great point. And again, I think shout out Vietnam veterans, because this is something that we've heard about with Agent Orange originally, and realizing that that was a particular instance, but the issue remains the same. And it's really great to see we've been able to build off of what they've done for us. I think we're going to go ahead and wrap up, unfortunately. But I just want to give you all just kind of like a last parting shot. Anything to kind of leave with the audience, or anything you want to?
Yeah,
about?
during the introductory remarks, it was stated that like the guiding star, the North Star, has been discussing with veterans, not about veterans, and that really stood out to me. So I really appreciate that from everyone here. And then also, I would just like to say my piece, my guiding star since I've gone out of the military has been that every veteran should maximize their legal entitlements and use them in a way that honors the fallen who never had the same chance. We're up here. Thank you. The only reason we're here today is because we survived. So I'll leave it at that.
Absolutely. Thank you so much. Jordanna?
Oh, good. I'll say that ending piece for me is it is difficult for a lot of us. The hardest thing I think for a lot of us is actually admitting, when we need help, when we're struggling, when we have anxiety, when we're not eating, just the smallest things for us, is hard to admit, but we'll absolutely raise our hand to help another person when they're in need. And for us, that's a really big commonality for, like, when we know that the community's in trouble, we'll stand up and say, okay, how do we help this community? And then once it's done, we'll go back to our dark hole and be very, very depressed because we're like, okay, what's going on? And so I'll say many things that we always say is like, check in with one another, reach out to one another, and, know that just because someone is smiling doesn't mean they're having a good day. It just sometimes means that we're trying to mask so no one asks us, how are we doing? And a lot of us know how to do that very well. And I'm very guilty of it, but definitely, check in with each person because it absolutely, really is beneficial, because just that how you doing, is really, really can start a conversation with someone.
Absolutely. Thank you so much. Jordanna?
So two thoughts, I guess, just to wrap up with is that first, I'm acutely aware that the benefits that I had, right, those were earned on sort of the backs or in the footsteps of the veterans that served before me and all of the advocates. And I can appreciate how sometimes it's a really thankless job. I worked for 6 years in the veterans advocacy space, and I was invited to leave, and it turned out that was like the best choice for me mentally and emotionally. I think it is, it can be hard work. And so I guess, thank you, right? There's a million different ways to serve, whether it's in the military or as a spouse or a child or a parent, or, and just to, give yourself some grace and compassion as we all navigate, the benefit, whatever. I'd navigate life. Yeah, for sure.
No, absolutely. I really appreciate it. And first, of course, thank you all for, joining, participating, sharing your stories, your candor, your insight. It's greatly appreciated. Our VP, Avital, is going to bring us home, but I also want to thank everyone joining today. that are, you're doing that hard work. I know a lot of veterans yourself, and this is very taxing, so I can't thank you all enough for what you do. Our friends at RAND for continuing to guide our work and being such a resource for us. If you definitely haven't checked out the report, can't plug that enough, but also all the other great resources they have. So thank you all for joining. I appreciate this.
Hi, everyone. I'm Avital Havusha. I'm the Vice President of Programs at the NYHealth Foundation. I'll keep it brief because I want everyone to be able to digest some of the great conversation that we just heard. And so a few more thank yous. I also wanted to thank our team at the foundation, Derek Coy, Liz Ward, and Shannon McCall, who really pulled this day together. David always says if it looks easy, that means there was a lot of hard work that went into it. So we really appreciate their hard work. And on behalf of the foundation, I really just wanted to also thank the RAND team, Jeanne and Carrie, who's here, for putting in such hard work on this product and for sharing the findings with us today. And to our panel, Jordanna, Jacob, and Gavin, you really brought a lot of the findings to light for us with your stories, and that was really the idea. Data points are only offer us so much, and so we really appreciate you being so candid and sharing your stories with us, and I hope they resonated with everyone on the room and online. And as we talked about at the beginning of the day, this needs assessment was really a follow-on from something that we did 10 years ago, and that original body of work has been our North Star of sorts, to make sure that our work has been guided by the needs, priorities, and preferences of veterans. And I hope that the new needs assessment can help us continue to work together on our shared goals. I'm really focused on some of those policy changes and community-based interventions that we've talked a little bit about here today. We heard about some of the challenges and the stories behind those challenges, but I know that so many of us in the room and so many people online are really leading the programs on the ground and the policy change efforts on the ground to meet veterans where they are, to build research, to build public and private partnerships and grassroots movements to make change. And so many of you have been the ones who have built those initiatives and who have scaled them across the state. And so I hope from here we can leave this room, dig more into the findings, continue this conversation about how we can work together, and to listen to veterans and ground our work in their stories. And so I'll leave us with that, and I hope everyone has a wonderful afternoon, and thanks for joining us.